Today we are going to be talking about musculoskeletal disorders. And I have a little overview for you here with some of the topics that we're going to be talking about. I'm really excited that you're here today. And over the next 2 hours, we're going to walk through some high priority musculoskeletal conditions. We're going to go ahead and focus on the things that you absolutely need to know for the NCLEX as well as for clinical practice. And we're going to go ahead and divide the session into 3 focused learning blocks. We're going to start with one of the most common degenerative joint conditions, osteoarthritis, also known as OA. And in this section, you're going to learn about how osteoarthritis develops, who's at risk for it, and how to assess and manage it effectively. And then the next session is going to be on rheumatoid arthritis, also known as RA. And during this time, we're going to contrast that with rheumatoid, with kind of osteoarthritis and talk about some of the differences. And we're going to talk about how rheumatoid arthritis is an autoimmune condition that actually presents itself pretty differently. And we're going to cover some hallmark signs of it, some hallmark labs. And we're also going to talk about morning stiffness versus joint deformities and how to kind of interpret and differentiate those different things on the exam. And then we're going to jump into an emergency condition. It's called compartment syndrome. And then also we're going to talk about fat embolism. And these are actually trauma-related emergencies. They're definitely NCLEX hot topics, and they do require immediate nursing action. So we're going to talk a lot about priorities. I'm going to teach you how to recognize some subtle early signs of these conditions, as well as what interventions are most time sensitive. And then we're going to finish and wrap up our webinar with some practice questions and some critical thinking so you can apply what you learned. And you're also going to get tips on how to eliminate distractors, how to use priority frameworks like ABCs, and the Maslow's hierarchy of needs, and also, of course, staying calm under pressure when you're taking the exam. This is going to be your time to ask questions, to review, and to build mastery of these topics. So let's get ready to lock in the details that show up on these exams and also that help to save lives at the bedside, because we're learning this not just for the test, right? We're learning this so that we can be amazing nurses. And in the meantime, as I go back and forth between the slides and the chat box, I will go ahead and look for questions. If you guys have questions, feel free to type them up and drop them in the chat box. And I will also have your participation during the questions. I'm going to have you guys help me read the questions and then go ahead and help me answer them as well. We can have discussions. I want you guys to feel comfortable with unmuting yourselves and showing yourselves on camera. And, if you need a small break in the middle there, like a bathroom intermission or go refill your coffee, you guys let me know. If for any reason at some point we're having any tech issues, I can't hear you, or the slides aren't showing up correctly, please let me know. Feel free to drop it in the chat box, let me know, and we'll go ahead and work through it together. But in the meantime, I'm going to go ahead and get started here. But before I do, I'm going to see if you guys have any questions so far. I don't see any questions. So let's go ahead and jump into this presentation. All right. So first, I'm going to tell you a little bit about me. You may have seen me before during the webinars or answering question rationales in the test banks. My name is Maria. I'm an RN, and I have about 8 years to 9 years of experience in healthcare. I've worked in lots of different fields, and I'm excited to help you, break down these topics and kind of make them a little bit easier to understand. So feel free to ask away whatever it is you want to ask about. I'll go ahead and share all my knowledge with you. And then, of course, whether you're learning this for the first time or you're just reviewing information, this is designed to really give you clarity and to help you feel confident to master these topics on the exam as well as in real life. And then, of course, we have a little icebreaker here. If you guys want to drop your name, where you're from, and if you're taking the exam for the first time in the chat box, or if you're retaking it, or if you're already a nurse and you're just transferring your license, whatever it is, feel free to share with each other on the chat box, build your community. And of course, like I always say, feel free to unmute yourself, say hi, show me your beautiful faces. This is our kind of online virtual classroom, so we want to get to know each other. But I'm going to go ahead and start you guys off with a little bit of an overview on the musculoskeletal system, give you a little bit of a recap here. And it looks like my picture got, the link got broken, which that makes me sad. Let me see here if I can refresh it. Probably not, but that's okay. I basically just had an anatomical photo there of the musculoskeletal system. And the musculoskeletal system is a heavily tested system on the NCLEX, especially when it comes to the areas of mobility, injury, and chronic joint diseases. And the musculoskeletal system actually includes a lot of different components. One of them is the bones. The bones give the body structure, um, you know, structure, right? That's what it gives us. It allows us to stand and to move around. It also stores minerals like calcium and phosphate. The muscles are another part of the musculoskeletal system, and they work together with the bones to generate movement in the body. And the joints are where two or more bones meet, which allows for flexibility. We also have tendons, which connect the muscles to the bones, and we have ligaments, which connects bones to bones. And then we also have cartilage, which is a smooth tissue that actually cushions the joints. Now, functionally, the musculoskeletal system is responsible for protecting organs. So think about, for example, the ribs protecting the heart and the lungs, and also for helping us to move around and to bear weight. And then we also have a really important function, which is producing red blood cells via bone marrow, also known as hematopoiesis. From an NCLEX standpoint, what you're going to want to focus on is chronic disorders like osteoarthritis, rheumatoid arthritis, which both require different interventions, and then also emergencies like compartment syndrome and fat embolism syndrome. And these are going to test your ability to recognize life-threatening complications early on so we can intervene. My apologies, I have allergies, so I'm like rubbing my nose. um, and then we also have age-related changes, like when you think about bone density that decreases with age, especially for women, and then also joint stiffness, which also gets worse with age. Of course, it depends on the person's lifestyle, but these do increase the risk of falls and fractures, which is a huge safety priority for older adults. And we know that that's a really hot topic on the NCLEX. And then also remember to always be ready to assess neurovascular status using the 6Ps, right? I don't know if you guys have been in the clinical setting before, either as an RN somewhere different or as a different unlicensed assistive personnel. And or if in another healthcare profession that you've worked in, but I don't know if you've done a neurovascular check, but that's going to include assessing for pain, pallor, pulselessness, paresthesia, and paralysis, as well as poikilothermia, which is also known as coolness. Now, understanding the musculoskeletal system is going to help you to connect the pathophysiology to the physical assessment findings and nursing interventions, which are going to be key NCLEX skills. So I'm going to jump back to the chat box for a second here. And oops, my apologies. And see if you guys have any questions for me so far. So I do see some participation here. I see hi, good evening. I see Ebony has a second attempt. I see Na is a retaker, Gideon from Ghana, Gertrude from Ghana, Helena from Montreal. I do have slides to share, and these slides are actually uploaded to the NCLEX website. Whenever you're about to join the meeting, it gives you the option to download the slides. And then also after our meeting, this will be uploaded to the NCLEX website, and it will also be, it will have the slides attached to it. So you guys can go ahead and download them afterwards. I see Peshu from Kenya, Nikki from Nigeria. We've got friends from all over the world. I love that. I love that we're able to gather together here from all these different cool places. I'll keep saying hi to you guys and checking into the chat box. But I'm going to go ahead and jump into osteoarthritis here, also known as OA. And osteoarthritis is a chronic, non-inflammatory joint disorder. That's one of the things that differentiates it from rheumatoid arthritis. It's non-inflammatory. It actually results from mechanical wear and tear of the articular cartilage. So that's going to be a big defining difference between rheumatoid arthritis and osteoarthritis. This one is from mechanical wear and tear. And this is actually the most prevalent form of arthritis, and it's often associated with aging, even though younger individuals with joint injuries or younger individuals that have repetitive use of their joints may also be affected. And osteoarthritis does not cause systemic symptoms, unlike rheumatoid arthritis. Here's another difference, right? So, rheumatoid arthritis is going to cause systemic symptoms because it is an autoimmune disorder. Because this is localized to mechanical wear and tear and overuse, it's not going to have systemic symptoms. It's going to be localized to the joint and the surrounding structure around the joint. And basically it's caused by over time the cartilage in the joint is eroding away, right? So that causes the joint spaces to narrow, and then there we have bone on bone friction. That's going to increase, and then it's going to cause pain, stiffness, and limited function. So that's really what OA is about. So we have a little bit of a review here about OA. And like I talked about, it's a mechanical wear and tear disorder, right? And it is like I said, the most prevalent form of arthritis. It is pretty preventable because of how it comes to be. In OA, the cartilage that cushions the ends of the bones usually starts to break down. And then the erosion of this cartilage is going to lead to friction and pain during movement, right? And then the body tries to compensate by thickening the bone underneath, which is called subchondrosclerosis. And then you end up getting small bone outgrowths, which are called osteophytes, or also known as bone spurs. These things will develop because of the body trying to compensate for the loss of the cartilage in the bone. And so inflammation can happen with OA, but it's not the primary. It's actually secondary to the mechanical tear. And like I said, it's primarily a non-inflammatory degenerative condition, unlike autoimmune types of arthritis. And then in addition to everything I described, the synovial fluid in the joints also becomes a lot less viscous or thinner, which further reduces the lubrication of the joints. So let me know if you guys have any questions.
Can you ask someone to turn their mic off?
All right, let me see if you guys have any questions here. Oh, I heard some background noise. Yeah, guys, if you could turn your mic off for now. When we do want some participation, I do want to hear you guys, but turn it off for now while I'm talking. And then if you want to say something and like You can interrupt me, but if you want to say something and I'm not hearing you, drop it in the chat box and then I'll give you space to talk. And I see some more introductions here. I see Ala from Armenia, Cheryl from the Philippines, Joy from Canada, and Rachel from Nebraska. Welcome, guys. Thanks for being here. All right. So, since we talked a little bit about the pathophys, I do have a mnemonic here for you. I know you guys asked me for mnemonics, and if you do want more, different things in the presentations, do let me know. Give me suggestions in the chat box of what else I should be adding. I do have pictures too, so it'll be kind of scattered here and there, photos, um, mnemonics, things like that. But this one is worn for each of the letters of the word. W for wear and tear, O for osteophytes, which is the bone spurs, R for reduced joint space, and N for non-inflammatory. This is actually a great mnemonic. It's nice and short, and it just kind of really helps you to remember what osteoarthritis is and what are the hallmark signs of it. Now, age is actually the strongest risk factor for osteoarthritis, and that's because of the accumulated wear and tear on the bones, as well as the reduced capacity of the body to repair itself in the cartilage. So, when we start to lose cartilage as we get older, the body is not as capable of repairing itself. Now, there are some other risk factors like obesity, which can increase the stress on the joints, particularly on the knees and the hips, right? Because those are the joints that are really holding our bodies up. Um, and then we also have repetitive joint use, which can be really common in specific athletes as well as certain jobs. And I did put a picture here of a farmer and a construction worker because those are two of the occupations that have some of the highest rates of osteoarthritis because they have a repetitive use of their joints. Now, we also have another risk factor here, which is postmenopausal women. Postmenopausal women do tend to have a higher incidence, and this is typically because of hormonal changes in the body that can affect the bones. Now, if there is a positive family history, that can also suggest a genetic predisposition to osteoarthritis. And it's really important for us to know these factors when assessing a patient during our interviews with our patients, because these factors can help to guide our lifestyle counseling and also prevention strategies, right? So this is going to be another thing you want to look for on the NCLEX. You may have a question, asking you about a certain patient. They're going to tell you their risk factors, and maybe they're going to tell you like, what is this patient, predisposed for, or what should be included in their education according to these risk factors. So that's why it's important to understand what the risk factors are for each of the conditions that we're talking about. Now, osteoarthritis pain is a mechanical pain because, again, it's due to overuse or aging changes, right? So, what this means is that this pain actually gets worse with use and improves with rest. So, that's a hallmark sign of OA. Is your patient may tell you, I woke up feeling good, but as the day went on, my joints started hurting more because of use, right? They're using their joints. So the mechanical action of using their joints is going to make the pain worse. And then when they lay to bed at night, it's going to feel better because they're resting their joints. So that's going to be a hallmark difference between RA and OA. So remember that. Um, so we talk about, morning stiffness. That's something that we interview our patients about when trying to figure out like, is it OA, is it RA? And actually be pretty brief. Like they're going to wake up, they're going to feel a little bit stiff for about 30 minutes or less, which is unlike the prolonged stiffness with rheumatoid arthritis, which would be a lot longer than that. They would probably wake up feeling a lot of stiffness, and it would last a lot longer than about 30 minutes. And then we might also hear some crepitus, right? I don't know if you guys are familiar with the term crepitus. You've probably heard it in different contexts when it comes to nursing. But crepitus is going to be a noise of kind of like a rough bone surface rubbing together. So that is something that you will hear with patients that have OA. They may also notice bony enlargements, right? We have Heberden's nodes, which can happen at the distal interphalangeal joints. which are going to be in that picture there. You see at the very tip of the finger, we have Heberden's nodes, and then we have Bouchard's nodes, which are going to be at the proximal joints, right? And we call the distal joints dip and the proximal joints pip. So D for distal, P for proximal. And these are going to be important distinctions in NCLEX style questions to differentiate osteoarthritis from rheumatoid arthritis. And I do have a mnemonic here, crepitus. It's kind of a longer one, but it does help you to remember. And it's going to be C for crepitus, R for range of motion, which is decreased in OA, E for enlarged joints, which also is another word for, or another phrase for bony nodules, P for pain with activity, I for inactivity stiffness, but it's brief, and T for tender joints, U for used joints, which are worse, and S for subtle inflammation. So the diagnosis of OA is often going to be based on a history as well as a physical exam. And imaging is going to support the diagnosis as well, right? We're going to do x-rays for sure. X-rays are going to be the first thing that we're going to do if a patient is showing signs of OA through their history and physical exam. And x-rays are going to show classic features like joint space narrowing. And we're also going to be able to see bone spurs on x-rays. We're also going to do some lab work. We're going to do we're going to do some ESR, right? And CRP. And usually these are going to be normal because osteoarthritis is not an inflammatory condition, right? We talked about how it's mechanical wear and tear, whereas in RA for rheumatoid arthritis is going to be different. But ESR and CRP are usually going to be normal with osteoarthritis, unless they're having some kind of a combination of the two. And then we might perform some joint aspiration in order to rule out infection or gout. So if they're having specific inflammation in one joint and we want to know what it is, we might aspirate some joint fluid in order to rule out if there's a joint infection going on or if they have gout, which can also present itself with some similar symptoms. And osteoarthritis synovial fluid is actually going to be clear and non-inflammatory with a low white blood cell count. So that's how we would know. So if you get a question related to that, remember that. Now, to manage osteoarthritis, the management is going to be tailored to the severity of the symptoms that the patient is experiencing. Of course, the first line is always going to be non-pharmacologic, right? We always go from non-pharmacologic and least invasive to most invasive and most, pharmacologic or toxic. So the non-pharmacologic conventions are going to include weight loss, right? This is going to be a huge modifiable risk factor that we can utilize to help our patients suffering from OA. And we're also going to have them do low impact exercises. This is going to reduce the load on the joint and it's going to help to maintain function. The other thing it's going to do is it's going to strengthen their muscles around their joints so that their muscles can provide a stronger support. And then I have some examples here of low impact exercises, which would be like swimming and cycling. And then when it comes to pain relief, we're going to use Tylenol or acetaminophen or paracetamol as the first line for mild to moderate pain. Now, if this is not effective, we might move on to NSAIDs, but these are going to be used with a lot of caution because these patients are going to have regular chronic pain, right? So that means they're going to be utilizing this medication chronically or long term. And we know that NSAIDs can have effects on the kidneys as well as on the GI system, right? It's a high risk for ulcers. So we're going to utilize those with caution. We're going to educate our patients on that. And for localized osteoarthritis, we may use some topical treatments like capsaicin, which is like the main compound in hot peppers. And that's going to help to lower inflammation, as well as it's going to have an analgesic effect to lower the pain. And we can also use topical NSAIDs that can be really helpful for the pain. We can also use some physical support like braces for their joints. And if our clients are suffering from really advanced osteoarthritis, we may consider joint replacement surgery, like for the hips or the knees. this can actually dramatically improve their quality of life. So it's a strong consideration there. Checking to see if you guys have any questions here. I don't see any so far, so I'm going to go ahead and keep moving forward here. Now I do have a little section on Q's and A's for you guys. These are just some questions that may come up for you as we talk about osteoarthritis. These are going to solidify some core distinctions between OA versus RA. We know that RA is going to be autoimmune, whereas OA is going to be non-inflammatory of a mechanical nature. And we need to learn some preserving interventions that are going to help to preserve functions in the client's bodies, right? And then on the NCLEX, I want you to expect to know how to differentiate arthritis types based on symptoms, labs, as well as imaging. I mean, they're likely not going to have you like looking at imaging to read what the image looks like, but they might give you a combination, right? So I want you to be confident in prioritizing lifestyle changes and recognizing, for example, like the Heberden or Bouchard's nodes on the distal and proximal joints of the fingers. Now let's talk about these questions. We have what symptoms help to differentiate OA from RA, and the main one would be morning stiffness of less than 30 minutes in osteoarthritis versus prolonged morning stiffness with rheumatoid arthritis. And then what imaging findings are expected in OA? We're going to see some joint space narrowing, right? The joint space is going to be a lot smaller than usual. We're going to see osteophytes or bone spurs, which is the body's way to compensate for that space narrowing. And we're going to see sclerotic changes. Now, what is the first line pharmacologic treatment for osteoarthritis? And that's really just going to be symptom management, right? Because we can't really stop the progression of it other than with non-pharmacological ways, like we talked about, but we can manage the pain with acetaminophen, not NSAIDs. And the reason why, again, is because NSAIDs are such a high-risk group medication. And then what lifestyle change can help to reduce OA symptoms? That's going to be weight loss and low impact exercises. And these are really underrated on the high and the high effectiveness that these interventions can have on a patient with OA. You know, they seem simple, but they're going to be really, really effective and helpful. And then which nodes are found at the dip joints, which again, D for distal, right? That's going to be, if you think distal distance is going to be a distance from the center of the body. And that's back from when you learned anatomy. So which nodes are found at the dip joints? And it's going to be Heberden nodes. Let me see if you guys have any questions about what we talked about. And if not, I will move on to our next section. Let's see here. I do see a question in the chat. I see here, can you get rid of Heberden's nodes with surgery? That's a really good question. I actually am not 100% sure about that. I don't think so. I think the Heberden nodes are going to be such a like a hallmark physical change of the body because of like the bony spurs that I really don't think that it's going to be possible to remove them with surgery. But with joint replacement surgery, they may be decreased. There's not really a way to fix the appearance of them. But again, with surgery and joint replacement, the function of the fingers is going to be a lot better, right? They're going to be able to do physical therapy afterwards and really, really improve the function. But the nodes might not necessarily be able to be gotten rid of. It is going to be kind of like an aesthetic problem. That's a good question. Thank you for that. You guys have any more? And you're welcome. So if you have more questions, drop them in the chat box. I will check back in. But I'm going to go ahead and move us forward into rheumatoid arthritis. Now, unlike osteoarthritis, RA is not going to be related to wear and tear. It's not going to be a mechanically caused condition. It's actually going to be an autoimmune disorder that causes the immune system to attack the synovial lining of the joints. And this is actually going to lead to a lot of inflammation for the client, a lot of swelling, and eventually it is going to destroy their joints, kind of in a mechanical way, right? So it's kind of the opposite because with osteoarthritis, you have the mechanical destruction of the joint that leads to inflammation. And in rheumatoid arthritis, you have the inflammation that leads to the mechanical destruction of the joint. So RA is usually going to present itself symmetrically, not asymmetrically. So with osteoarthritis, because of overuse, you may have, let's say the left knee is having, an osteoarthritis destruction or like wear and tear. Whereas in rheumatoid arthritis, you're going to have both knees. It's going to be a symmetrical presentation. It's going to happen on both sides of the body. Like it could be both wrists, it could be both knees, or both hips. And it's also associated with systemic issues like we talked about before. And some of these issues are going to be like fatigue, malaise, like just really feeling crappy all the time because it is autoimmune related and it is related to high inflammation in the body. And this is actually a lot more common in women that are aged about 30 to 50 years old. Now let's talk about the pathophysiology here. The immune system with rheumatoid arthritis is going to mistakenly target the synovial fluid, which leads to an inflammatory response. And over time, it's going to create something called a pannus. It's spelled Pannus. And this is actually a granulation tissue that grows over the cartilage and the bone. And the pannus is going to erode the joint structures and it's going to cause fibrosis, which can lead to something called ankylosing, which is permanent joint fusion. Now, this process is going to be really progressive. It's going to happen over time, and it's going to result in the loss of function and deformity of the joints if not managed properly. And we do have a mnemonic here, RAPAN or RAPAN, and it's going to stand for pannus formation, autoimmune attack, and nodes, as well as the erosion of the cartilage and bone. Now, rheumatoid arthritis is often going to start in the small joints, and it's going to be like the fingers, the wrists, and the toes. And then it's going to progress to larger joints in the body, like the knees and the hips, the shoulders, maybe. And pain is typically going to be worse in the morning, and it's going to last more than an hour. We talked about how osteoarthritis would have a little bit of stiffness in the morning, probably under half an hour. But for RA, somebody's going to wake up and they're going to feel really bad, and it's going to last quite a while. And then, of course, osteoarthritis is going to improve with rest, whereas rheumatoid arthritis likely will not improve with rest. And you may see an ulnar deviation or a swan neck deformity or boutonniere deformity. There's lots of different deformities that you may see with RA. You're also going to see rheumatoid nodules, which are going to be firm lumps under the skin. And this is actually going to be a classic finding of rheumatoid arthritis. You're also going to see fatigue, possibly even low-grade fever, and this is going to reflect systemic symptoms of arthritis or of rheumatoid arthritis. So remember, low-grade fever, fatigue, malaise. It's going to be a lot of systemic symptoms, right? So I can see how with these symptoms, you would be able to pretty quickly differentiate between two patients that have osteoarthritis versus rheumatoid. And we do have a mnemonic here, which is joints, and that's going to be J for joint stiffness, overall fatigue, I for inflammation, N for nodules, T for tender joints, and S for symmetrical swelling. Let's see if you guys have any questions. Does RA improve with activity? It can, absolutely. So, doing the right kinds of activity can actually help to improve the symptoms of rheumatoid arthritis. And we are going to talk about interventions in a minute here. So let's talk a little bit about diagnosis because RA is actually going to combine a couple of different things. We're going to look at clinical findings, of course, and we're going to look at some lab results. Now, lab results are going to be really important in the diagnosis of rheumatoid arthritis because we're going to confirm inflammation with an elevated ESR and CRP. So when those two lab values are elevated, that is going to signal towards inflammation for us. And then we might even have a rheumatoid factor. Now, this is only present in about 70 to 80% of cases. And we have something called anti-CCP antibodies. These are going to be a lot more specific to rheumatoid arthritis, and these are going to happen earlier than the rheumatoid factor. Now, rheumatoid factor and anti-CCP may not be present in all rheumatoid arthritis patients either. We're also going to do some imaging, and this is going to help us to assess the damage that's being done to the joint, especially to the hands, the wrists, and the feet, since we start off with smaller joints, right? And then, of course, the earlier rheumatoid arthritis is diagnosed and treated, the better the long term outcomes. We actually do have a lot of treatments for this condition. All right, let's go on to our next slide here. I like to give you a minute or so before I move on to make sure you got everything. So let's talk about some treatment options here. The goal for rheumatoid arthritis is going to be to slow the progression of it as well as to manage the symptoms. And we have a drug group called DMARDs, which is disease modifying anti-rheumatic drugs. These drugs are going to be the first line defense against rheumatoid arthritis. And one of the most famous ones is going to be methotrexate. This is going to be the most used medication. What it does is it suppresses immune activity. But again, as nurses, we know that this is going to come with a whole host of risks and complications, right? Some of these risks are going to include liver toxicity as well as bone marrow suppression. So, being a good nurse, we know that we're going to look for signs of infection if somebody is on this medication, as well as signs of liver toxicity, right? Like jaundice, like RUQ pain, things like that. Those are some of the precautions with the DMARDs medications. Now, we're also going to use NSAIDs and steroids because these are going to help with short term relief during RA flares. However, these are not going to stop joint destruction, right? So they're going to stop the inflammation a little bit. They're going to kind of manage some of that inflammation when our patients are having rheumatoid arthritis flares, but they're not going to stop the progression of the joint destruction. And we do have some non-pharmacologic interventions here, like low impact exercise, as well as joint sparing strategies. We're going to do lots of physical therapy that's going to be really helpful for rheumatoid arthritis, and it is going to actually help to manage their pain as well. Learning functional body movements that can teach our clients how to move more intentionally in the ways that are not further damaging the joints. That's going to be a really great intervention. Again, exercise, physical therapy. And we want to go ahead and combine kind of an approach of all different modalities for these patients. Now, surgery is definitely an option, but it's going to be for more advanced cases. We may do something like a joint replacement if the joint has been, destroyed to a point of no repair. And we may do synovectomy. We have a mnemonic here, RAMETH, for kind of a abbreviation of the word methotrexate, which is that medication we talked about. This mnemonic is going to help you remember some of the drug therapies that we do, right? So M for methotrexate, which is the main DMARD that we use. E for etanercept, which is a biologic. T for therapy, like physical or occupational therapy. And H for hold NSAIDs or steroids for flares only, right? Lots of precautions with those medications. We know that NSAIDs cause renal problems and GI problems, and we know that steroids can affect the body in so many ways, like blood sugar management as well as the immune system. Now, talking a little bit more here, diving into the DMARDs medications, again, they do treat inflammatory conditions like rheumatoid arthritis because they reduce inflammation and they slow down the progression of the disease. And what they do is they actually work by targeting the immune system, and they prevent further damage to the joints and other tissues. So, again, suppression of the immune system. Now, they're not going to relieve pain like some other medications. They're kind of going to work over time because what they do is they modify the underlying process of the disease, right? And they're going to reduce the likelihood of damage to the joint and they're going to improve long term outcomes too. So it's not a single line defense here. It's going to be, again, a group of different modalities that are going to be treating this condition. And then let's go ahead and talk about some questions and answers that you may have here to kind of reinforce some NCLEX concepts about RA. Um, we're going to talk about early identification and treatment priorities, as well as differences between the two arthritis types. And I want you to be ready to prioritize lab results and recognize some systemic clues, like we talked about fatigue, malaise, low grade fever. We know that that's RA, not OA. And of course, we want to be able to educate our clients about lifestyle and medication safety, like we talked about the DMARDs, the NSAIDs, and steroids, right? So we have here what distinguishes RA from OA, and that's going to be the symmetrical joint involvement and the prolonged morning stiffness. Again, OA can happen on one side, whereas RA will present with both sides. Now, what antibody is more specific for RA, and that's going to be the anti-CCP antibody. What is the first line medication for RA? That's going to be the methotrexate. And what side effect requires holding methotrexate? And that would be related to the two precautions I told you about, low white blood cell count or liver toxicity. So if your patient's coming in on methotrexate and they're showing signs of right upper quadrant pain, jaundice, and even signs of infection, what's the first priority going to be? That's going to be for you to hold the methotrexate and notify the physician, right? Now, what physical therapy advice is going to help RA clients? That's going to be to use warm compresses, to rest during their flares, because they are going to be having inflammatory flares since it is an autoimmune condition, and to perform gentle range of motion exercises to go ahead and maintain mobility in the joints. Are the risk factors for RA same as OA? What a great question. And I also see what are the complications of OA and RA. Let me go ahead and answer those questions for you guys. And then, just so you guys know, right after this one, we're going to jump into our trauma emergency, the fat embolism, and the compartment syndrome. So the risk factors for RA and OA are going to be a bit different. And the reason why is because these are two very different types of arthritis, right? We talked about how with OA, we have a degenerative wear and tear and a mechanical wear and tear of the joints. So of course, like we talked about, we're going to have the risk factors of old age, obesity, repetitive joint use, potentially joint trauma or injury. There may be a genetic predisposition. We talked about the female sex with hormones being more predisposed to it. Now, for rheumatoid arthritis, because it is a chronic and a systemic autoimmune disease, we're going to have different risk factors, right? So this is actually going to be a lot more common in females. That one's actually kind of similar to OA, but with this one, it's going to be a lot more common in females. It's going to be 2 to 3 times more common in females than in males. And with OA, we have the elderly being higher at risk, right? Whereas with RA, we have ages of about 30 to 60 being more common. So typically, a woman in middle age would be the most at risk for RA. Now, of course, we know a family history of RA is always going to be genetically predisposing to these clients. But we have some other risk factors as well, like smoking is going to be a really strong risk factor for rheumatoid arthritis. And we also have some risk factors like environmental triggers, like infections, or we have hormonal factors or stress that can also lead to autoimmune conditions. So that's going to be kind of the differences there. And kind of if you want me to like kind of compare and contrast with OA, we have about greater than 50, right? So more in the elderly group. RA, middle age, 30 to 60. Um, the cause for OA would be wear and tear, whereas the cause for RA would be autoimmune. The gender for OA would be greater in females, gender for RA greater in females. However, with RA, it's even greater because with OA, we can still have the other risk factors. Like there could still be a male that has had an occupation with repetitive joint use that's in his 60s, and he's going to have some really high, strong risk factors for OA. For rheumatoid arthritis, there's no direct link to obesity, whereas for osteoarthritis, there is a direct link because of the excess pressure on the joints. And then for osteoarthritis, we have no systemic symptoms, whereas RA, we have lots of systemic symptoms. And then smoking is going to be another difference. Risk factor for rheumatoid, whereas not for osteoarthritis. I hope that answers your question. Let me know if that was helpful.
So, Professor,
Yeah.
for osteoarthritis, you said smoking is not a risk factor, right?
For osteoarthritis, no, but for rheumatoid arthritis, yes.
Yeah, I got that point. All right, thank you, Professor.
Yep, yeah, absolutely. And that's because of course rheumatoid arthritis has an autoimmune, relation, whereas osteoarthritis doesn't. And we know that smoking definitely increases inflammation in the body. So now let me go ahead and answer the question here. See, what are the complications of OA and RA? Great question. Let's go ahead and go into that. So for osteoarthritis, we're going to have some mechanical complications, right? They're going to be a lot more localized. So we're going to have chronic joint pain, which is going to reduce our client's quality of life. We're going to have a lot of decreased range of motion and joint stiffness, which again can reduce their quality of life, right? Like, oh, let's go on a hike. You know what? I can't. I'm really in pain from my knees, and the decreased range of motion. We're also going to have joint instability and deformities, right? Like the knees may buckle and they may have disturbances to their gait as well. We know that the elderly age group is already at an increased fall risk, but if they have osteoarthritis, they're going to have even more disturbances to their gait. So we need to be very cautious of that. They're also going to get potential muscle atrophy because they're going to be, underusing their muscles because they're going to be afraid of movement, right? They're going to be in pain, they're having instability, decreased range of motion. So potentially over time, that could lead to muscular atrophy. And they're going to have some functional limitations because of the pain and the instability. So that could impair their ADLs, right? Their activities of daily living may be impaired because of that. That could also lead to joint effusions, which is fluid buildup in the joints. And we also talked about the osteophytes, which are the bone spurs, right? The little bone spurs or bony overgrowths of the joints. So these patients may need assistive devices. They may need canes. They may need walkers to stabilize their gait, to be able to be mobile. They may need a total replacement surgeries, like for their knees or their hips. And we have to really watch out for them being a fall risk because of their joint instability as well as their pain when they're walking. Now, when it comes to complications from rheumatoid arthritis, we also have joint deformities. They're going to look a little bit different than the osteoarthritis deformities. And we may have really severe disability from their joints being completely destroyed from the inflammatory process. They may have osteoporosis in the future. Rheumatoid arthritis is more associated with osteoporosis because of the chronic inflammation as well as the steroid used to manage the condition. We're going to have rheumatoid nodules, which we talked about. We may have vasculitis, which is a really scary complication that can affect the skin, the nerves, and the organs. And we may develop pericarditis or pleuritis, which is an inflammation of the lungs or the heart tissue, right? That's going to cause chest pain, dyspnea. This is kind of like a rare, more on the rare side, but definitely a possible complication. And because of the systemic inflammation, we have a lot of other conditions and complications that we think wouldn't even be related to the joints, like interstitial lung disease. We may have dry eyes and mouth. We may have increased risk for cardiovascular events like MI or stroke. These patients may be depressed and have a lot of fatigue because of the inflammatory process. They're not able to do as much. They're not able to sleep because of the pain. They may be depressed because of their decreased quality of life. And they may have a lot higher risk of infections because of their immunosuppressive therapy, right? We're trying to suppress the immune system to decrease the inflammation over time that's destroying the joints, but in turn, that's putting them at risk for different infections. So one thing is getting better while one thing is potentially more at risk. And we know that rheumatoid arthritis is going to affect more than the joints. Again, lots of systemic symptoms. They might have long-term steroid use, which can lead to adrenal suppression, can lead to osteoporosis and infection. And of course, we need to think about them taking the medication methotrexate over time, which may lead to toxicity, right? So we're going to advise don't drink any alcohol while you're on methotrexate because of the liver impairment. So I hope that answers your questions. And if you guys have any more questions, let me know. So I'm going to go ahead and move forward. You're very welcome. It's a pleasure. These were great questions, by the way. Thank you guys so much for asking that. So let's go ahead and talk a little bit about compartment syndrome and fat embolism. So compartment syndrome, I don't know if you've ever seen a picture of it. It looks really scary. It's really like graphic. So I didn't put any pictures on this presentation. I would say looking at pictures of compartment syndrome, when I was in nursing school and I saw pictures, I was like, oh my God, they should put a warning because it looks so graphic. I know we're all healthcare workers and we're used to seeing things like that, but you know, it's still, unless you want to see it, I don't recommend you look it up. But if you want to see it, you know, curiosity, it's fine. And I do hope that you never have to see this in a clinical setting, but it is a really scary complication. And we want to know how to treat it, right? How to identify it early so we can prevent loss of tissue and necrosis, and potentially even loss of limb. So let's go ahead and talk a little bit about it. Compartment syndrome is actually caused by increased pressure within a closed muscle compartment. And it can happen most often because of bleeding or swelling after a fracture. So a patient who has had trauma or a fracture is at risk for compartment syndrome. Now, if they have a tight cast on one of their limbs, that can make it worse because it will prevent the limb releasing that pressure, right? So the pressure is going to build up in there. And it's really scary. This is actually a life-threatening complication of trauma. And you need to be able to recognize it quickly in order to prevent limb loss or even death. Now let's talk a little bit about fat embolism. This is going to be more of a systemic problem. It's going to occur when the fat globules from the bone marrow actually enter the bloodstream. And this can also happen after a fracture, especially of long bones like the femur. And both conditions are most common, usually within 24 to 72 hours post-injury or post-surgery. So if your patient just had a fracture or trauma, within 24 to 72 hours, you really want to be alert to these symptoms. So let's talk a little bit about the pathophysiology. And I do have a mnemonic for you here. It's the word femur. Again, common, the fat embolism is common with long bones like the femur, right? So for fat embolism, we have fracture of the long bone, emboli, mental status changes, underlying trauma, and respiratory distress. Now let's talk about the breakdown of what's really going wrong here in compartment syndrome, there is a lot of pressure, and this pressure is happening in a closed muscle space that exceeds the capillary perfusion pressure. And what that's going to do is it's going to stop the blood flow, right? There's not going to be any blood flow, and that's going to lead to necrosis, which is tissue death. This is definitely a surgical emergency. And the only fix to this is going to be a fasciotomy, which is when they cut the fascia to relieve pressure. So the pressure is going to be building up in the muscle compartment. There won't be any blood flow, any oxygenation. The tissue will start to die. And when we recognize the symptoms of that, we're going to have to send them directly to surgery. And in that surgery, they're going to cut open the fascia or the tissue in order to relieve the pressure. Now, if we let this go on for a few hours, there could be irreversible damage done to the area because of the ischemia, the lack of oxygen, right? The lack of blood flow. So the muscles and the nerves are going to die, and we need to go ahead and recognize this early and intervene early. Now, when it comes to the fat embolism syndrome, we're going to have fat droplets that are escaping the bone marrow after trauma, and they're going to block small blood vessels. And this can happen especially in the lungs and the brain, which is obviously like two of the most important areas of our bodies, right? For oxygenation and for cognitive function. Now, this could mimic a pulmonary embolism, but it's actually caused by fat, not a clot. But it can also cause confusion, dyspnea, and a petechial rash, which is kind of a spotted red rash on the body. The difference here is that compartment syndrome is going to be localized pressure after trauma or surgery, whereas the fat embolism syndrome is going to be the fat getting released and causing systemic issues, right? So it's a systemic emboli. But both can be caused by the same thing.
Can I have a question, please?
Absolutely.
So that means pulmonary embolism and fat embolism, the differentiation is going by the clinically. Yeah, because the clinically is developed the same, but predisposing for fat embolism, we have a long bone fracture, which is developing. Yeah, fat.
Absolutely. So if we are having somebody who is having symptoms of a pulmonary embolism that could be confused with a fat embolism, but we know the key difference is that they just had a fracture, that could be our defining factor there. Now, there's going to, of course, we're going to utilize different diagnostic factors too. We're going to do, for example, we're going to do a chest x-ray, right? Whereas with the pulmonary embolism, it may be normal, or we may have some infiltrates. Whereas if we have a fat embolism in the lungs, there's going to be a different look to it. It's kind of going to look a little bit like a snowstorm in the lungs. And then we may have some different labs that we may run too. Like, for example, with a pulmonary embolism, your D-dimer is going to be really elevated, right? Whereas with a fat embolism, it may be normal, or it just may be a little bit elevated. But there's going to be a lot of different things about it too. Like with the PE, you're not going to have the petechiae. You're not going to have that rash on the body. Whereas with the fat embolism, you will. But some of the other symptoms may be really similar, like the anxiety, the confusion, the agitation, the chest pain. Those are going to be very, very similar symptoms between the two.
Thank you.
You're very, very welcome. Absolutely. And that was a great question. So let me see here. Let's go ahead and look at some of the clinical manifestations. So what does it look like, right? So pain out of proportion is actually going to be your biggest red flag for compartment syndrome, especially if you give them pain medications and the pain doesn't improve. So they're going to have really, really, really severe pain in that area, right? So they had a fracture. It's expected that they're going to have some pain, but it's not going to be as horrible as this. Like, they're probably going to be reporting 10 out of 10 pain and be, just really, really severely uncomfortable. Now, after the pain, this person is going to start experiencing paresthesia, which is numb and tingling, right? Like You're going to touch them. You're going to do a neurovascular check. They just had a fracture. Now they're feeling like 10 out of 10 pain out of nowhere. You've given them pain meds. They're not feeling better. Now you're going to do a neurovascular check, and then you're going to touch it, and they're going to tell you, okay, it's numb. I'm feeling some tingling there. You're going to check their pulses in that limb. Pulselessness is going to be another sign. However, this is going to be a later sign of it, right? This means that circulation has been completely cut off to the area. And this is definitely going to mean that it's too late, but of course, we still have to intervene at that point. And then if our patient is having a cast after a fracture, we need to go ahead and be assessing their neurovascular status often, just to make sure. So when we're doing all of our other assessments, depending on what your doctor ordered, like Q2, maybe you'll be checking neurovascular status, but you should at least be checking it once in a while. And then that limb may become cool to the touch, which is also a really scary sign that there is no circulation to the area. So remember your 6 Ps. These are going to be really important when it comes to NCLEX. Now, talking about the fat embolism, the classic signs are going to be systemic, right? Because we know that it's going to be affecting not just that specific limb. It's something that got released into the body. So classic signs are going to be hypoxia, right? Confusion. And then they're going to have that petechial rash, which I have a little picture there of what that rash looks like. But it's usually very distinctive, right? This petechial rash is going to show up around the neck and the chest. That's usually your first clue that something is going on. Combine that with your other, your clinical history and the whole clinical picture. Like, this person had a fracture, now they're feeling suddenly confused, out of breath, and now they have a rash around their chest. That's going to be a red flag hallmark sign for a fat embolism. So you want to go ahead and watch for these patients, especially if they're having a femur or a pelvic fracture. Now, of course, they're going to have some fever, they're going to be tachycardic, and their O2 sats are going to be dropping too. And I do have a mnemonic here for fat clot, for the fat embolism, and that's going to be fever, altered LOC, tachycardia, chest petechiae, low oxygen, and over 24 to 72 hours onset, as well as trauma. Now, the emergency management, these are going to be interventions that are going to save lives. Again, these are going to be emergency conditions, right? So if you suspect one of these conditions, you need to act fast. And there is no embarrassment on saying like, oh, hey, I suspect that this could be going on. If it's not that, great. We don't want that to be happening to our patients anyways. But the small chance that it is, we want to go ahead and catch it early and intervene. So if you suspect compartment syndrome, don't elevate the limb, don't apply ice. That could actually worsen the ischemia, the tissue death, right? The lack of circulation. You're going to go ahead and keep that limb at heart level, and you're going to notify the provider immediately if you are suspecting compartment syndrome, because there's really nothing you can do at that point. That patient just needs to go to surgery and get a fasciotomy, right? So you're going to go ahead and notify the physician and prepare them for a fasciotomy to relieve that pressure in the muscle compartment. Now, for a fat embolism, oxygen is going to be the first priority. You want to go ahead and get that oxygen set up right away, and you're going to sit that patient up unless, of course, it's contraindicated if they have some other, condition or situation that doesn't allow you to sit them up. But you're going to go ahead and sit them up in high Fowlers and apply oxygen right away. And you're going to prepare to escalate care for them immediately, right? They may need ICU level support care at this point. They may need mechanical ventilation if ARDS does develop. Now, make sure that you never delay when a client shows loss of pulse or respiratory changes after a fracture. These are going to be your 2 key symptoms, right? If they're showing loss of pulse in that limb, or they are having respiratory changes after they had a fracture, you want to go ahead and act quickly. Now, these questions are going to talk about some critical thinking and rapid response scenarios here that the NCLEX wants you to master about these conditions. So when you see signs like unrelieved pain, confusion, or a rash post-fracture, you want to go ahead and act quickly. And you also want to know when to escalate and recognize the signs before they become irreversible. because they can definitely cause loss of limb or death for your patients. So what is the first symptom of compartment syndrome? And that's going to be pain that is completely out of proportion to injury. And then which assessment finding is going to be more specific to fat embolism, and that's going to be the petechial rash on the chest and the neck area. And then what is the priority nursing action for a suspected compartment syndrome? And that's going to be to notify the provider and prepare for a fasciotomy. Now, what
Can you explain?
Sorry, go ahead.
Can you explain a fasciotomy?
Yeah, absolutely. So in a fasciotomy, they're basically going to go ahead and cut open the tissue in order to relieve the pressure that's inside the muscle compartment. So it's going to be basically the only limb and life-saving intervention for somebody suffering from compartment syndrome, because they have so much pressure building up in there that's blocking circulation that there's no way that their limb is going to be saved without the fasciotomy. So the surgeon is going to make an incision through the fascia. It's going to relieve the pressure, and it's also going to prevent permanent damage to the muscle and the nerves. Now, this can typically be performed on the arms or the legs. That's usually where you're going to see compartment syndrome happening, and they will leave the wound open in order to let the swelling subside, because it's going to be really swollen and full of pressure in there. So they're going to cut it open and they're going to leave it open, and it's going to look pretty gnarly for a while. And it is going to require lots of dressing changes, right? They're going to be sterile dressing changes to prevent infection. They may even have like something in there to remove the fluid. And it might even require skin grafting later in order to kind of, you know, um, improve the aesthetic appearance of the limb, depending on how bad the complication was. I hope that answers your question. If not, I can go into it more. Let me see if you have any more questions here. Please go back to the previous slide. Did you guys want me to go back to, let me see here. Is it this one? I hope that helps. And like I said, if you want to go look up what compartment syndrome looks like, if you haven't seen it, and look up what a fasciotomy looks like, if you're into like surgery and cool anatomical stuff, it looks pretty wild. But if you have a sensitive stomach, then you might be like, whoa. All right. Let me know if you guys have any more questions. And if you guys want a little 5-minute intermission here, I'll go ahead and give you guys a couple minutes so you can use the restroom or grab yourself a refill on your water or your coffee. And we will go ahead and jump into some strategies for test taking that I always talk about. You may have seen it before. You may have heard me talk about it, and I'll just reiterate it for those who haven't heard it. And then we are going to jump into some practice questions that we're going to do together that are NCLEX styled. And we're going to go over all the rationales for the correct and the incorrect answers together. Now I'm going to go ahead and answer some of these questions for you guys here. I think I stopped at number 3. Number 4 is going to be what intervention is contraindicated for compartment syndrome. So if you see a question on the NCLEX that says your patient has compartment syndrome, they're suffering from this, this, and this, they're having pulselessness, paresthesia, out of proportion pain, what is the first intervention you're going to do? And then one of them says elevate the limb above the heart. Definitely a huge no, definitely a contradiction, a distractor. Do not put that. That is going to be very contraindicated, like I said, because it's going to make the ischemia worse. It's going to contribute to tissue death. So you want to go ahead and keep it at heart level and notify the physician right away. And then a patient with a femur fracture becomes confused and tachypnic. What should you do first? Well, you're going to sit that patient up in high fowlers and you're going to apply high flow oxygen. Going to make sure that this fat embolism doesn't progress in the time that we are notifying the physician. So I'm going to give you guys a couple minutes here. If you have any questions, go ahead and chime in. All right. So let's go ahead and talk a little bit about our strategies here. I'm going to go slow for those of you that are still coming back from taking a little break, using the restroom, refilling your waters, all of that. So there's lots of different strategies that we're going to use on the NCLEX, right? And these strategies, they're kind of like preparing for an emergency, right? When you prepare for an emergency and you make a plan, it's not because you think an emergency is definitely going to happen, but it's because you have a plan. In the moment when you are in that emergency, you're going to be feeling like nervous, anxious, you're going to have fear, you're going to be, I don't know what kind of test taker you are. Maybe you get really scared during tests. Maybe you get really anxious and it blocks you from being able to really use your critical thinking and remembering the things that you studied. So having that plan in place and having those strategies and tools in your toolbox, that's what's going to help you to, take your test in the most effective way while still dealing with your fear and your anxiety, right? So like I said, during an emergency, why do we make a plan? We make a plan so that if an emergency happens, we know what to do when we're freaking out. We're freaking out, but we're like, okay, I don't know what to do. I don't know what to do. I'm freaking out, but at least I have a plan. So I'm just going to go ahead and follow this plan. So with our strategies here, that's going to be the same thing. Is there's just going to be tools in our toolbox that we're going to pull out and use during our test. And we're going to go ahead and utilize these to answer questions to the best of our ability, because there may be questions on there that you didn't really, maybe you didn't remember, or maybe you weren't there that day that we talked about it, or maybe there's just so many topics to study that you just didn't get around to studying that one. So these strategies may help you pick the right answer, regardless of that, right? So we have two really popular strategies here. One is going to be airway, breathing, and circulation, as also known as our ABCs. And we have our Maslow's hierarchy of needs, which is going to help us prioritize what to do first, right? And typically that's going to have to do with the patient's physiological needs. So I'm going to go ahead and jump into some of our strategies here. And like I said, if you've seen my webinars before and this is repetitive for you, you can take your intermission while I talk about it, or repetition's the mother of all learning. So you can stick around and listen. And elimination strategy is going to be one of the easiest ones to use. The way that we would use this is we would immediately eliminate the answer choices that we see right off the bat are contradicting medical facts. Like I said earlier, if somebody is having signs of compartment syndrome, do you elevate their limb? No, right? So that's us using the elimination strategy. We're removing a distractor or something that is like absolutely not correct. And then there's going to be terms on your answer choices that say always or never. And you're probably not going to choose those as your answers, right? Because usually it's not really clinically justified to say always or never, unless it is. If there is something that's definitely clinically justified, like never elevate your client's limb when they're having compartment syndrome, that's actually clinically justified. Now, when it comes to prioritization strategies, we're always going to use our ABCs. I know you guys have heard of this one. Everybody talks about this one in nursing. We're going to go ahead and prioritize our airway, our breathing, and our circulation in that order. And usually there is one trick. If something is more life-threatening than airway, then you would choose that over airway. But otherwise, It's always going to be airway, breathing, circulation. And then when it comes to Maslow's hierarchy of needs, if you have questions that are related to, should you do this or this first? What actions should you take first, or what client should you prioritize out of these 4 clients? And usually it's going to be the one that has a physiological need, right? If they have a physiological need, that's going to look like if they need oxygen, if they have pain, if they need to use the restroom, if they're hungry. So you're going to go ahead and take care of those physiological needs before you take care of any other needs, like their emotional needs or their social needs. And then our other strategy here is going to be ADPI, right? We have our nursing process, which is ADPI, which stands for assess, diagnose, plan, implement, and evaluate. That's an order of what we do in our nursing process. And that's just going to remind us what to do first, right? Now, the trick to this is if somebody needs intervention before assessment, like if they need immediate intervention, there is a life-threatening situation going on, you're always going to intervene before you assess. But otherwise, it's safe to say that you would want to assess them before you intervene, because you want to make sure that you are utilizing the correct intervention that's going to be effective for them. So definitely, like I said, it's not always going to be 100% this, but there are definitely exceptions, right? Like I said, if there is something going on that they need immediate intervention, you're definitely going to choose that first. Now, let's jump into our practice questions. We're going to have 10 practice questions here. And then, of course, we can discuss the answers. And, if you guys have questions about them, if you don't agree with the answer, let me know. But I'm going to go ahead and ask one of you to unmute yourselves and read question 1 for me.
A nurse is assessing a client for risk factors of osteoarthritis. Which of the following findings places the client at highest risk of developing this condition? A 35-year-old client who runs daily on concrete surfaces, a 60-year-old client with a body mass index of 34, a 40-year-old client with a history of asthma, a 50-year-old client who consume a high sodium diet. Based on the lecture that you gave, I'll go with letter B.
You are
Body
absolutely
mass
correct.
index is kind of high, and
Yep.
considering the age factor as well.
Yep. You're absolutely correct. Good thinking. I love that you applied that. And everybody else in the chat is saying B too. So you guys agree. This is definitely correct. They have 2 major risk factors listed in option B here. So we know that our 60-year-old client is going to be that age-related risk, and the body mass index of 34 is going to put a little bit excess pressure on their joints, right? So it's definitely going to increase the risk of developing OA. And we know that having obesity or having a higher body mass index can sometimes be also associated with higher inflammation. Now, that's not to say that somebody with a higher body mass index can't live, a healthy lifestyle. Absolutely. People come in all different shapes and sizes. And actually, it's uncomfortable sometimes to hear that so much can be in the medical world associated with obesity. And I think that sometimes when you go to a doctor's appointment and sometimes they tell you like, oh, well, you need to lose weight. That's not the only thing they should be focusing on, right? They should be focusing on many different things. But for certain conditions that can actually be associated, and again, some people that have a higher body mass can have a higher association to inflammation. That's not always the case. And in this case for osteoarthritis, the only main association with that is going to be because of the excess weight on the joints, right? But that's not to say that we should judge clients that have, higher body mass index for all kinds of conditions. And that's just to kind of add a little bit of an inclusive side note there, because those are things that I notice, right? When I'm learning and I'm talking about these things, we want to bring light to that. So let's talk about why the other answers weren't correct. Option A was a 35-year-old client, definitely not at the age group that's at risk for osteoarthritis. However, running on hard surfaces can definitely increase stress on the joints. So if he was a 65-year-old running on daily on concrete surfaces, I would be concerned. And then the 40-year-old client with a history of asthma, again, asthma is unrelated, right? So this is something where you could have used that, um, well, we talked about our strategy here of removing distractors, right? So we eliminate distractors. This is a distractor answer. The age group is wrong, and asthma has nothing to do with osteoarthritis. And then the 50-year-old client who consumes a high sodium diet, definitely also not, a risk factor. High sodium, again, is not really related to that. So another distractor here. However, high sodium can contribute to other health issues, right? We can have hypertension, but again, not really related to the joints. So definitely not the right answer. And then I'll have somebody read number 2 for me.
Okay, we have a nurse is providing education. Oh, my place is very noisy. A nurse is providing education to a client newly diagnosed with osteoarthritis. Which of the following instructions should the nurse include in the teaching? Select all that apply. Number 1, use cold packs on joints during active inflammation. Perform high impact aerobic exercise regularly. Limit movement of the affected joints. Take scheduled rest period to reduce joint stress. And E, avoid weight bearing exercise.
Awesome, thank you. Sorry about the structuring there. It looks like the E got grouped in with the D, but thank you for reading that correctly. And thank you guys for volunteering to read with me. It's always nice having participation. So feel free to tell me what answer you think it is, or tell me in the
A
chat box.
and D.
Yep, you're so right.
A and D.
Absolutely. You are correct. I love the way that you're applying your knowledge. And let's see what everyone's saying in the chat here. I see some different answers. I see C and D, A and D, C, D, and E. So let's talk about why some of these were not the answers. So first of all, our client is newly diagnosed with OA, right? So we're providing education to them, and we want to go ahead and choose what we're going to include in the teaching. So option A, use cold packs on joints during acute inflammation, and option D, take scheduled rest periods to reduce joint stress. Now, the reason why option A is going to be a good answer is because cold packs are going to help with inflammation, right? We know that rheumatoid arthritis, we're talking about osteoarthritis here. We know that osteoarthritis is going to have a lot of acute flare-ups, just like RA, right? Just like rheumatoid arthritis. But putting cold therapy is actually going to help to reduce swelling because heat expands tissues, right? So that's going to help to reduce the swelling, and it's also going to help to numb the area a little bit. So that's going to be a really nice, non-invasive intervention for us to teach this patient. And again, we always want to start with least invasive and non-pharmacologic if we can to reduce risks. Now, option D, take scheduled rest periods to reduce joint stress. Absolutely. Why? Because osteoarthritis is a mechanical condition, right? It's going to be happening due to overuse, to wear and tear. So resting is going to help to those joints to recover a little bit. It's going to help to reduce the injury, the strain. But we should also remind them, don't be completely immobile all the time. You still need to have moderate low impact exercise, whatever it is that you can do to move and to keep your joints mobile, to keep your muscles mobile. You still need to do that. But if you're having an acute flare up, rest is going to be a really good intervention. Now, option B, perform high impact aerobic exercises regularly. Not good, right? High impact is going to be like running, jumping, like it's going to be like, for example, doing burpees, like things like that. Definitely is going to be really hard on those joints. People with osteoarthritis is not going to benefit from this. They're going to benefit from things that are more low impact, that are going to improve their function, that are going to teach them to use functional movement, and that are going to improve the strength of their muscle without putting extra strain on the joints. And then limiting movement of the joints is not going to be recommended either, right? Because even though if they're having an acute flare-up, we do want them to rest a little bit, but moving their joints is going to help keep their joints mobile, and it's going to improve function over time. And it's also going to reduce pain. If they're still and stagnant all the time, that's actually going to make pain worse, and their joints are going to become a lot more atrophied, and their muscles are going to become atrophied. So we definitely don't want them to decline over time. So we want to recommend rest during flare-ups, but still continue to have moderate functional movements. And then avoiding weight bearing exercises is also not recommended. And the reason why is because these are actually going to be really beneficial for people with osteoarthritis. Weight bearing exercises are going to improve bone density, and they're going to strengthen the muscles around the joints in order to kind of give them a bit of extra support. And it's going to reduce pain too. So, again, not high impact, we want low impact, but we also want weight bearing exercises. So, it's going to be some really effective interventions for our OA patients here.
I have a question.
Yeah.
So basically for osteoarthritis, you use like a cold compress, and then for RA, you use like a warm compress. Is that how it goes?
It depends. I think a cold compress can also help with rheumatoid arthritis as well because of the inflammation. So cold is really helpful for inflammation in general. So it's going to be helpful for both of them. But again, that depends on the person, right? So sometimes actually if you're having a flare up and your joint is really inflamed, the cold therapy is going to help to reduce inflammation. But sometimes if you're having really bad stiffness, the warmth may help to kind of bring some blood flow back to the area. So it's kind of on a case by case basis. But overall, if you're having an OA flare up, the cold therapy is going to be really helpful. So I will have somebody help me read question number 3.
A nurse is reviewing a client with suspected osteoarthritis. Which of the following findings is most indicative of the condition? A. Erythrocyte sedimentation rate significantly elevated. B. Symmetrical joint space narrowing on radiographic imaging. C. Evidence and Buchan's note on physical examination. And D. Positive nuclear antibody test. I think it's C.
Yep, you're right. Absolutely. And you guys are all correct because I see you guys saying C in the chat box too. So you're applying the knowledge correctly. And it is going to be C. And the reason why we talked about the Heberden and Bouchard's nodes, right? Those are going to be hallmark symptoms of osteoarthritis. They're going to be located at the distal joints and the interphalangeal joints of the fingers. And the proximal joints, and they're going to be characteristic findings of OA, right? And we saw a little bit of a picture of it. These are going to be the little bone spores that we talked about. Because the bones are kind of rubbing up against each other, the body tries to compensate and creates little bone spurs to kind of build some distance between them, but it ends up turning into these nodes. Now, the reason why A was incorrect, if you guys remember, ESR is going to be a marker for inflammation, and it's going to be a lot more common with rheumatoid arthritis, not with osteoarthritis, because osteoarthritis is a non-inflammatory degenerative joint condition. Now, option B, symmetrical joint space narrowing on radiographic imaging. This is going to be a lot more characteristic, again, of rheumatoid arthritis rather than osteoarthritis because, again, we have the asymmetry, right? With osteoarthritis, we can be affected on one side and not the other, whereas because rheumatoid arthritis is systemic, we're going to have it on both sides. And then the positive anti-nuclear antibody, this is actually going to be more indicative of an autoimmune condition. Again, lupus and rheumatoid are going to have a lot of similarities. This is a test that can be present with lupus or rheumatoid arthritis, but not common with OA because, again, it's a mechanical source rather than an inflammatory source. So for question 4, if anyone wants to read that with me.
Nurse is reviewing the diagnostic criteria area or rheumatoid arthritis, which is the student nurse. Which of the following findings supports a diagnosis of the rheumatoid arthritis?
Thank you so much for
I
reading.
think it's I think it's more B,
Absolutely.
because asymmetrical joint involvement could be, but more symmetrical is coming for the rheumatoid arthritis, and
Yep.
the rheumatoid factor. This is approval for the rheumatoid arthritis, and the Haber's note is more explaining for osteoarthritis. And morning stiffness usually for rheumatoid arthritis is taking longer than 10 minutes before the patient
Yep.
start moving.
Absolutely. You are correct. It is option B. And I love your rationales for the wrong answers, because that's exactly what it is. We know that the rheumatoid factor is going to be associated with rheumatoid arthritis. It's usually going to be elevated. And like I said before, not all patients with rheumatoid arthritis will have this, but if they do have it and they have the symptoms as well, then that's going to be a diagnostic factor there. Now, again, asymmetrical joint involvement is going to present with OA, not RA. And then the Heberden's nodes are also going to be associated with OA, not RA. RA is going to have some different characteristics to it, as well as different deformations. And it's also going to affect the larger joints, right? Now, morning stiffness less than 10 minutes, definitely RA related. We saw that OA is going to have a shorter time, right, about less than 30 minutes. And RA is going to have a longer period of time of morning stiffness. So good job applying your knowledge there. And thank you guys so much for reading the questions with me. Question 5, who wants to join me?
A nurse is preparing educational materials on the diagnostic tests used for rheumatoid arthritis. Which of the following tests are commonly used to support the diagnosis of RA? Select other apply.
Thank you so much for reading that. And feel free to answer if you want to take a shot at it. Let me see if you guys are saying anything in the comments here. We have C, we have B, we have E. We're a little bit divided on this one. So it is a select all that applies. So let's go ahead and break this question down, right? So we know the nurse is preparing educational materials, and we're talking about diagnostic tests that are going to be used for RA. And we want these tests to be relevant to support the diagnosis of RA, right? So we have X-ray, we have a SPECT scan, we have the C-reactive protein, we have a joint capsule biology, and we have the anticyclic citrullonated peptide antibody, or ACCP, like we talked about earlier. So if you guys remember correctly, our imaging is definitely going to include an X-ray. Because of the inflammatory nature of RA, we're definitely going to be doing AC-reactive protein. And we also have the ACCP antibody involvement here. So the answers are going to be A, C, and E. And the reason why is because X-rays allow us to visualize what is the damage to the joint, right? Do we have erosion? Do we have deformities? Like, what is the disease progression looking like? X-ray is actually going to be first line diagnostic for both RA and OA. So we're definitely going to be looking at some imaging. And our C-reactive protein, again, inflammatory marker, right? It's going to be elevated just like the ESR. And it's going to go ahead and let us know what is the level of inflammation in the body with this person with RA. And then the anti-CCP is going to be really specific to rheumatoid arthritis, and it's going to be a very, very reliable test. You might see it on the NCLEX. A positive anti-CCP test can support RA even in the early stages. So this is actually pretty promising because there's so many different ways that we need to assess the patient to see if they have RA. So with the anti-CCP being so definitive, that's going to be a really, really important test.
What's SPECT scan?
Sorry, go ahead.
I'm just asking what SPECT scan?
Yeah, so a SPECT scan is not, like it says, excuse me, like it says, it's not typically used for rheumatoid arthritis. It's going to be used for bone abnormalities. So it's not really something that we do. But let me go ahead and see if I can show you a picture here. Let me find a picture online for you. So that's kind of what the scan looks like. It looks a little bit like an MRI, and it's going to go ahead and scan. I hope you guys can see it. I shared my tab here with you guys. It's going to go ahead and scan for bone abnormalities. And it stands for, it's a long word. It's a single photon emission computed tomography. So it's going to be more of like a nuclear nature, right? And it's going to involve sort of a CT scan and also like a gamma camera. They're going to inject the body with a radioactive tracer, which is a little scary, right?
Right.
Some of these tests can be a little bit scary. And it's used often for like when somebody's having a brain disorder, if they're having, like I said, bone abnormalities. And then you have to consider, of course, that there is a radioactive exposure during this test, but it's going to help to visualize, again, like I said, bone abnormalities, the blood flow in the body, as well as metabolic activity of the body. So it's going to be a really helpful scan, but not really a scan that we hear about a lot, right? And definitely not used for RA. And then the option D here, the joint capsule biopsy, not really used for RA either. This can help to kind of differentiate RA from other joint diseases, but it's not a routine test. And anybody that saw option D may have confused it with that the joint aspiration where we study the synovial fluid of the joint. Not necessarily the same thing here. This is going to be actually a biopsy, which is a different procedure. So let's go ahead and jump on to question 6 here. Who wants to read this one with me? And I hope I answered all your questions. I'll check back in, in the chat box here and make sure that you guys aren't asking anything else.
A nurse is reinforcing education about treatment plan for a client newly diagnosed with RA. Which of the following medication is the first-line long-term treatment for this condition? A. Prednisone, B. Methotrexate, C. Ibuprofen, D. Leflunomide. I think it's B. Methotrexate.
Yep. And this is like a really straightforward question, right? Like definitely B methotrexate. I'm sure you guys remember that word is hard to forget. It's the most important first line DMARD medication that we use to treat rheumatoid arthritis because it helps to slow the progression of the disease, right? We know that when the disease is progressing, the inflammatory process is destroying the joint. And what this is going to do is help to slow that inflammatory process. It's going to suppress the immune system that's attacking the body, and it's going to help to decrease that damage to the joint over time. And of course, the earlier that we find that this person is suffering from RA, the better, because the medication is going to be a lot more effective. And as we talked about before, it does have a lot of risks, right? The two main risks are going to be liver complications, and the other one's going to be the immunosuppression. So you want to go ahead and think about those precautions and how they relate to your interventions and your assessments to your patient. And then, of course, go ahead.
Yeah, what are the contraindications for methotrexate?
Yeah, so that's a great question. So if somebody has a liver, any type of liver disorder, or if they have a history of drinking alcohol, that's going to be a huge contraindication to methotrexate, and the reason why is because it can lead to liver toxicity, right? So we want to go ahead and decrease the damage that it could potentially cause to this person. And the other thing is going to be if this person is pregnant, right? If they're pregnant, they can't take methotrexate. This is going to be a really high teratogenic medication. It's going to potentially cause birth defects. So we want to go ahead and make sure that pregnant people are letting their doctors know, hey, I'm planning on getting pregnant, and I want to go ahead and get on a different medication for my rheumatoid arthritis. Again, liver disease, huge one. If they have renal impairment, that could be a consideration. Depending on the progression of the disease, the doctor may, weigh out whether that's going to be okay for them or not. Again, alcohol use is going to be a huge one because it is excreted by the liver and it can cause a lot of liver problems. Again, think about the immunosuppression factor. If your patient has any type of active infections, if they have like bone marrow suppression, if they have had cancers before and they're already on immunosuppressive therapy, this might not be a good option for them, right? Because it may even further reduce their immune system and lead to infections, or if they are having an active infection at the time, that would prevent them from healing. If they have peptic ulcer disease or they have ulcers or they've had them in the past, we want to be aware of their use of methotrexate, and we want to go ahead and teach them lifestyle modifications to make sure that it's not causing further damage to their GI system, because it could cause GI bleeding because of that. So yeah, so those are going to be kind of the contraindications here. Thinking about the immunosuppression factor of it too, if they are having a live vaccine. So if they got like they're traveling and they're getting a live virus vaccine, like an MMR, for example, we want to go ahead and talk to them about the immunosuppressive effect of the medication.
Thank you so much.
Yeah,
So
absolutely.
I have a question. So in case of this contraindication, what other medication will now be used for this client?
Yeah, absolutely. That's a great question. So let me go back to my slide here, actually, that talks about some of the different medications that we use for RA. Let me see. Treatment options. There we go. So we do have other medications that we could.
We have the etanercept.
Yeah, absolutely.
Then you
So
ask
we
us to use therapy as well, and
and
also
we would be
steroids
considering.
in the case of
Yep.
flare-up.
Exactly. So we would be considering like what are the other therapies that can complement, what other medications can we use for them? Of course, are they using their non-pharmacologic strategies as well to help to manage the condition? But there would definitely be other medication options. And, of course, this comes down to what does their lifestyle look like and what other factors, how can we utilize like these medications to the best of our ability to help this patient, right? So we still have other DMARDs, which are methotrexate alternatives, right? We have the hydroxychloroquine. That's going to be safe in pregnancy, actually, even though it is kind of, all these medications are a little bit scary. But the hydroxychloroquine is going to be safe during pregnancy. The sulfasaline is going to be safe during pregnancy as well, but this one's also going to have some issues with the GI system. Or if, of course, if they have clients that are allergic to certain medications similar to this one. And then we're going to have other medications that are not going to be safe in pregnancy, but maybe safe for other contraindications of the methotrexate. And then our biologics are going to be some of our other alternatives, again, like the etanercept, like you said. We're going to be using these, but we're also going to have other precautions with these medications, right? These are going to be a lot more expensive. And we're going to go ahead and screen them for other conditions before we give them, like tuberculosis. But these are still going to have immunosuppressive functions in the body. So that's kind of going to be the main line of defense, is going to be suppressing the immune system for these patients. Now, if they are having, for example, if the patient is also consecutively having cancer as a comorbidity, we're going to go on and choose other classes of medications too, depending on what types of cancers they have. So it's going to go pretty deep. With whatever conditions, their specific conditions they're suffering from, and their lifestyle in general, and how the physician is going to determine the best medication for them. But there will definitely be alternatives.
That's great. Yeah.
Yeah, absolutely. Yeah, we're definitely going to have lots of options for our patients here. So let me go ahead and go back to our questions. I think we were on question number 6. So if you guys don't have, let me go ahead and tell you a little bit about the other incorrect answers. Prednisone is going to be short term, right? We're talking about first line management of RA. So definitely not prednisone. That's going to be more for like flare ups. So we're going to use them once in a while, and we don't recommend them to be used a lot over time because they're going to have a lot of other effects on the body. Ibuprofen's an NSAID. It is going to be helped to manage the pain, again, during flare-ups, but it's not going to be a first-line long-term treatment that's going to manage the condition. It's just going to be kind of a Band-Aid, right? It's going to help manage the symptoms on a short-term basis. And the leflunomide is going to be another DMARD. It can be used for RA, but again, it's not the first-line defense. But it can be used in place of the methotrexate if the methotrexate is not being tolerated. So this is another one of those alternatives that we talked about. So for question 7, let me know if one of you guys wants to read it.
Okay.
A nurse is assessing a client who has a cast on the lower leg and suspect compartment syndrome. Which of the following finding is most indicative of this condition? A. Bounding period pulses and increased warmth in the foot. B. Pain that increases with passive movement and not relieved by opioids. C. Bruising around the cast site and mild swelling. D. Redness and drainage at the edge of the cast. I'll go with B, which is one of the 6 P's. The
Yeah.
compartment syndrome. Yep.
Absolutely. I love that. You guys are really applying your knowledge, like I said, and I love that. And that's a sign that you're going to do great when you see questions like this on the NCLEX. Thank you so much for reading and sharing your thinking with us. And it's true, right? This client has a cast. We're suspecting compartment syndrome, and we're thinking about what is the most indicative finding, right? And it's always going to be the out of proportion pain, right? It's unrelieved. Let's say we're giving them some Norco or a shot of morphine, and this client is still complaining of pain. We're definitely going to think compartment syndrome because that pain is going to, even if they're just doing very passive movement, because of all the pressure buildup in there, they are going to be feeling a lot of pain. It's going to be unrelieved because the pressure is not relieved, right? And the tissue is dying. So the body is screaming for help with that pain. So that's how we know. Again, that's going to be the hallmark symptom of compartment syndrome here. But we have some rationales for the incorrect answers here too. And bounding pedal pulses and increased warmth. Not necessarily, right? If the limb is warm and our pedal pulses are bounding, that's not going to show that we have ischemia or a lack of circulation. That's actually the opposite. So definitely we would be having cooler skin, right? The skin would be cool to the touch in the tissue, and we would have diminished or absent pulses, which would be a late sign of the compartment syndrome. Now for option C, bruising around the cast and mild swelling, this is actually pretty normal. If they just had a fracture, they had trauma, they had injury, it's going to be bruised, it's going to be swollen. That's normal. That's not a hallmark sign of compartment syndrome. It's going to be a pretty normal finding. And then option D, redness and drainage at the edge of the cast. This is more pointing towards infection, right? Like we have something going on in there, some process going on in there. We're draining some fluids, and it's red at the edges. It's definitely showing that there may be some infectious process going on that's localized. And now we want to go ahead and notify the physician and get an order for maybe antibiotics, right? So that infection doesn't become systemic, but not really associated as a hallmark sign of compartment syndrome. Question 8 here, one of my helpers. I would love that. And if you guys are tired, I can read too.
It says a nurse is caring for a client with suspected compartment syndrome of the lower leg. Which of the following action is most appropriate to manage this condition? A. Apply compression stocking to improve venous return? No. Losing any restrictive dressing or cast material elevate the extremity above the level of the heart, encourage ambulation to promote circulation. The answer is B.
Yeah, you're absolutely correct. I love that. And you know that from your critical thinking because you know that compartment syndrome is pressure building up, right? So you're not going to want to compress it even more. You're going to want to go ahead and loosen that. So great thinking. Thank you so much for reading and sharing your thinking with us. And yeah, so of course we're going to go ahead and loosen any restrictive clothing. Now, applying compression stockings, not necessarily. It's going to put more pressure. This would be used to manage different conditions, right? Not compartment syndrome. We know that C, elevate the extremity above the level of the heart. We're never going to do that. We talked about that. And encouraging ambulation is also kind of scary, right? We don't want them to ambulate on that limb. That could potentially increase the problem and increase the pressure. So we don't want them to be bearing weight on that limb. We're going to go ahead and leave that limb at the level of the heart, and we're going to go ahead and notify the physician right away and prepare that patient for surgery. So we know that those were not the answer. And then, of course, loosening any dressings or cast material. Again, we need to relieve the pressure. We already know that there's internal pressure building, but if there's anything externally that we can help to release that pressure, that's going to be a priority intervention even before we go ahead and contact the physician. So if you get a question that says your patient has a cast on, you're getting symptoms of compartment syndrome, you know, their limb is cool to the touch and there are no pedal pulses, what is the first action you're going to do? And then maybe it says loosen the or remove the cast, notify the physician, prepare for surgery. Those are all correct. But the first thing you're going to do is you're going to loosen the dressing or the cast. And the reason why is because you want to go ahead and loosen that pressure the fastest possible because you want to prevent irreversible damage. Like every minute counts with this situation. Option or question 9 here. Who wants to read this one?
A nurse is monitoring a client with a long bone fracture for sign of fat embolism syndrome. Which of the following finding is most indicative of this complication? Diminished breath sound with dullness to percussion, chest pain and ST elevation on ECG no, petechial rash on chest, neck, and upper arm, decreased bowel sound with abdominal. Everybody's answer is blocking my view. With
C.
abdominal distension. So the answer is the petechial rash. It's not
Yep.
diminished breath sound or chest pain. Yeah.
Yeah, no, absolutely. That is so true. And you guys remember that. And I stressed it a lot. That's going to be the hallmark sign of fat embolism syndrome. Good job. You're applying your knowledge. I love that. You guys really listened to everything we talked about. And that is going to be the sign, right? Petechial rash. They had a long bone fracture. Now they're having a rash. They're anxious. They're confused. You're thinking immediately, oh, crap, there's a fat embolism. I'm going to go ahead and sit them up. I'm going to give them high flow oxygen, and I'm going to notify the physician, right? That's going to be the most important interventions there. Now, diminished breath sounds with dullness to percussion definitely could potentially be a fat embolism, but not really associated with it as much as a pleural effusion or pneumonia. The biggest finding here is actually going to be hypoxemia, right? So they're going to have low oxygen. And then chest pain and ST elevation. Again, this could be an MI going on. This could be some kind of a cardiovascular event going on, not necessarily fat embolism syndrome. They are going to be tachycardic though, right? They're going to be anxious and they may be even grasping their chest, right? Because they're feeling like they can't breathe. But what this is describing is more associated with an MI. And then decreased bowel sounds with abdominal distension. This definitely sounds more like a bowel obstruction, some kind of a GI issue, a paralytic ileus, but not necessarily a fat embolism. So let's go ahead and read question 10.
Nurse is caring for
A nurse is caring for a client with fat embolism syndrome, FES. Which of the following is a priority nursing intervention? Administer intravenous corticosteroid,
Place the client in high Fowler position. Prepare the client for immediate chest tube incision. Encourage the client to cough and deep breathe every hour. I will go with B, because you have to put the client in a high Fowler position.
Yep, absolutely. You're correct. And all of you guys here in the chat box are saying the same thing. So you guys definitely listened when we talked about those interventions. Placing the client in a high Fowler's position is going to be the priority intervention for fat embolism, and then of course administering high flow oxygen to improve their hypoxemia and to increase their effectiveness of their
Marcos, Marcos, can you put the orange in the sink, please?
Say that again?
No. Marcos, put your bag up.
Please, can that person mute?
Let me see if I can mute you guys here. Yeah. Sorry, I thought somebody was asking a question. So I'll go on and explain here some of the incorrect answers. We have corticosteroids, IV. Although this can be used, again, it's not going to be the first line intervention, right? It's not going to be the priority. We need to go ahead and improve ventilation by sitting them up and giving them high flow oxygen. Preparing them for immediate chest tube insertion, not really necessary, right? Unless there's another condition going on. The physician would be letting us know if that was the problem, but we want to go ahead and improve their oxygenation instead. And encouraging the client to cough and deep breathe every hour. This is going to be more of a post-operative intervention to, prevent atelectasis, or if this client is having, pneumonia, we want to go ahead and do that. But this is not necessarily going to be associated with a first-line intervention for the fat embolism syndrome. So sorry, go ahead.
Yeah, I have a question here. So which one is the priority first? Oxygen administration of oxygen or high Fowler position?
I was about to ask the same thing.
Yeah,
if we see oxygen, then you see high Fowler. Which one should we go for first?
I love that question. That is such a good question. And it should always be positioning first. Usually we want to position that person because we're going from least to most, right? So that the first thing we're going to do is we're going to position them to improve ventilation. And the reason why is because when we give them the oxygen, we want the oxygen to be able to be effective, right? Because if they're laying down, they're supine and they're kind of like slouched over, and we're administering oxygen, it might not have the same effect as if we position them first. So we want to position them in high Fowlers first and then administer oxygen.
So do we say first and priority? Do we say it's the same thing?
Say that again?
In some questions, you get first. What do you do first? What do you do as a priority? So are we saying they both mean the same thing now?
Yeah, so we're saying we would position first. I would definitely position first. And that's what I've seen in most of the NCLEX style questions. When they have the option to position and give oxygen, usually positioning comes first.
And what's the priority?
The priority is to get that patient ventilated, right? So the priority is to get them
high Fowler.
Yeah, it's going to be the high Fowler. So sit them up in the high Fowler and then administer oxygen.
Thanks so much.
Yeah, absolutely. That's a great question. I love that. And I just want to talk a little bit with you guys now about what we talked about today. We talked about the differences between osteoarthritis and rheumatoid arthritis. We talked about some orthopedic emergencies like compartment syndrome. We discussed the 6 Ps. We talked about fat embolism. And then we also did some practice questions today. We got some mnemonics down. And then remember to always assess first and then intervene quickly unless intervention is required first. And then, of course, remember our early warning signs versus our late warning signs of these conditions, right? With OA and RA, not necessarily as important as it is with our orthopedic emergencies here. Again, the differences being with compartment syndrome, we have the 6 Ps, whereas fat embolism, we have the systemic symptoms, which are going to be the hypoxia, the rash, and the confusion. And then we have the OA versus RA, whereas one is degenerative, one is autoimmune. One happens on one side, one RA happens on both. And then, we have one with breakdown of the cartilage, which is the osteoarthritis, versus rheumatoid arthritis, which has more of a systemic inflammation. So So I hope that this presentation gave you guys lots of clarity today. I hope that you are leaving this feeling a bit more confident when it comes to taking the NCLEX. And I want to go ahead and share a link with you guys so you guys can leave feedback if you feel like leaving any feedback for
I have a
our
question.
session. Yeah, please.
Yeah, this is my first time. Actually, it was kind of like an accident that I got this webinar. So
Oh, I love it.
yeah, I'm just asking, is it always you're gonna conduct it always on Fridays?
Actually, we have webinars happening every day, pretty much. There is a schedule on the Naxlex website that you can access, and we have webinars almost every day. I think it's between like Monday to Saturday, and we usually have them at 2 different times. If you're on the East Coast or if you're on East Coast time, it would be 7 p.m. And 9 p.m. And if you're on the West Coast and you're on Pacific time, then it would be 4 p.m. and 6 p.m. And there's going to be lots of different topics. So I'm one of the instructors. We have other instructors as well that are going to be holding the webinars on multiple different topics of the NCLEX. And we also do record the webinars too when you want to go back and kind of review it before the test. You can find our uploaded webinars as well as the PowerPoint slides that are on the website.
Oh, that's great. Thank you so much.
Of course. Absolutely. I'm happy to hear
I
that.
loved it. I loved it.
Yay. Thank you. That makes me happy. I'm really happy to hear you loved it. And I love it when people come in by accident. They go on the NCLEX website and it's like, there's a webinar happening, and you click on it. Oh my gosh. I didn't expect that. But yeah,
I'm
thank you
about to
guys.
do my NCLEX, so it was so helpful.
Good. I love that. I'm really glad to hear that it was helpful. And I'm hoping that it was, right? And I left you guys a little link there in case you guys wanted to leave feedback. We definitely have a link there for, if you have suggestions or it's in the chat. I dropped it in the chat box. So if you want to leave any suggestions like, hey, this is what I want to see more, or if you want to say like, hey, she did a really bad job at explaining this, or she did a really good job of explaining this. Either way, we want to hear it. So let us know how we can do better to meet your guys' needs. And of course, as always, I enjoyed hearing you all, talking to you all, and seeing you guys. And yes, I see a question here.
Where can you find the recordings?
Sure. So there is a section on the Naxlex website that says previous webinars. And I have a screenshot of it. I'll drop it in the chat box so you guys can see it. But basically, you just click on previous webinars, and it's going to show you like where. There it is. I just dropped it for you guys. So it says previous webinars, and it's going to show you like a list basically of all the webinars that took place, the titles, what it's about, and it's going to have the PowerPoints too, so you guys can download those and review them. I know we're all different learners, right? So we want to like watch stuff, hear stuff, read stuff. So we're trying to give it all.
You're doing a great job.
Thank you so much. I'm happy to hear that. And I always enjoy hanging out with you guys. And I do have a webinar coming up tomorrow as well. And it's going to be a maternal newborn health one because earlier this week I had a mishap and my webinar didn't happen. So I will see you guys there if you choose to come. And if not, then I will see you whenever I see you.
Same time.
Yeah.
Okay.
Yeah, tomorrow is going to be 9 p.m. actually for Eastern Standard Time, and it's going to be 6 p.m. for Pacific Time. So yeah, so that's going to be taking place tomorrow, and it's going to be a pretty extensive one. Lots of different topics we're going to talk about. So I hope that you guys have a wonderful night. There is not another class tonight, so I hope you guys have a great night and a great weekend. And it was a pleasure seeing you all again. And I hope to see
you going to be lectured tomorrow?
What was that?
Are you going to be lectured tomorrow as well?
Yeah, I'm going to be there tomorrow. It's going to be 9 p.m. Eastern Time and 6 p.m. Pacific Time.
For the endocrine?
Tomorrow I'm doing maternal newborn health. I believe the
Matana.
endocrine is going to be
Endocrine is
12.
7 p.m. and Matana is going to be 9.
Yep, exactly. And
Okay.
our endocrine one is going to be taught by Therese. She's
Oh,
another
okay.
one of our instructors. So
Thank you.
you're welcome. I
Thank,
will see you guys
thank
next
you.
time. Thank you so much for everything.
See you tomorrow.
See you
You're
tomorrow.
welcome.
You
Bye.
guys have a wonderful night.
Thank
Bye.
you.
Good night. Thank you.
Bye.
Good night. Bye,
Right, thank
guys.
you so much.
Thank you.